Our last speaker of this session is Dr. Ganti, somewhere. Latha is an emergency physician. She works at our facility in Gainesville. Is that what it's called? You know, little internecine. Seriously. She has begun to forge a career as an exceptional investigator in neurotrauma and has forged many advances in management of this problem in the acute phase. So with great privilege and pleasure and pride, because she's a fellow Gator, I would like to turn the podium over to Dr. Ganti, who's brought her own hat.
Well, it is my pleasure and privilege to be here. I'm really glad I get to go early so I can get it over with and then I can enjoy the rest of the conference. So I'm Latha Ganti, just like it says over there. I'm a professor of emergency medicine and neurological surgery at the University of Florida. I will tell you about the Terrell Family Foundation endowed professorship that will be coming up later on. I also have the privilege of serving as the director for the Center for Brain Injury Research and Education. I recently finished a Fulbright scholarship last year, and I'm also the editor-in-chief for the International Journal of Emergency Medicine. My objectives basically are just to share my small part of the story in the whole TBI project. It's really difficult to go after Cindy. I was already nervous about my talk, and now I'm all emotional after the talk I just heard. So hopefully it'll be okay. So my objectives are just to share our little story with you. And I'm going to start off with the case because that's where I'm most comfortable and at least I can get back into it. So this is just daily life in the ER. There's a 37-year-old guy. He's a restrained driver, MVC on I-75. Everyday occurrence for us. Airbags deployed. His car flips twice before it crashes the median. There's a lot of front-end damage to the car. You know, our paramedics come in, they bring the photos, and we're not sure if he had loss of consciousness. But I can tell you he had no visible head trauma, he had no lacerations, no contusions, and basically the resident sees the patient, they come and they present to us. He wasn't trauma alerted because he didn't meet criteria, and so of course we don't think he has a traumatic brain injury. And he did come on a backboard, but we say, okay, we use these nexus criteria things. We say he's not intoxicated, he doesn't have any midline spinal tenderness. So we clear his collar, we just take it off, and he has a GCS of 15 after all, so how bad can it be? So our dispo is we say, you can go home, and we print like 8 or 9 pages of discharge instructions that essentially say nothing. They say, if you don't feel good, come back to the ED. And then when they do come back, we're really annoyed. So he does come back. He comes back the next day and he says, I have a headache, I have nausea, irritability. And so we're like, fine, you're here for the second time, so we'll do a head CT, okay? So that's what we're going to do for you. The head CT is negative, so we discharge him home. A week later, he comes back again because he's not able to function. He can't go to work. His wife is distraught. She comes in with him this time. She doesn't think he should be driving. They're like arguing in the trauma bay, and he feels he's fine. He says, oh, I've been to the doctor twice. You guys haven't done anything for me, so why should I be here? And of course, I'm sure no one is surprised, but he has no primary care doctor, and he has no insurance. Okay, so this is how I'm feeling. I just came to the University of Florida 3 years ago, and this was one of the first cases that I had seen, and from my perspective, I thought, okay, well, this person obviously needs to have follow-up. I'm going to call the TBI clinic, or I'm going to call some maybe head injury clinic, or maybe a trauma clinic. Well, there wasn't really anybody to call. So what I found out is that everything was really unsatisfactory. There was no standard ED TBI evaluation. We didn't have a protocol. There was no place that I could send these patients to follow-up. I wasn't even sure what I was supposed to do with them on follow-up ED visit because I was almost hoping the CT would show something, because if they have something, I can admit them. No awareness of post-concussive syndrome. I didn't even know what it was. And there's no organization for social services. We do have a fantastic emergency department social worker, but there are only certain things that they're able to do. So she said, what would you like me to do for him? So I said, well, I don't really know. So this is really how I felt at that time. And as all good things, I had this very fateful visit. And so this is the story I'm going to tell you. One of my friends, classmates, Tom, said to me, you know, I know you do all this stuff in brain injury. You should really meet this guy that I work with. I go to church with him. He's a great guy. And I said, oh, okay, that sounds cool. And then I find out he's an attorney. And so immediately I was like, oh my God, I'm going to meet an attorney. and it's one of these things where I've never had to interact with an attorney ever in my life, right? And so, like, I'm Indian, we have no attorneys in the family. Everyone is like in medicine or in business, and really boring. So I thought, oh, well, I hope I don't say anything, like that's going to get me into trouble, right? So I first was really excited, and then when I was about to meet, I was really stressed out because I thought, oh, I don't know how it's going to go. And I thought, why is this guy want to meet with me anyway? So all these apprehensions that I had and all these preconceived notions that I had, the minute I got to dinner and I met Frank, they all went away. Basically, when I got there, you know who I met? I met a man who was very similar to me. He was from an immigrant family, and his family came to the States to make a better life, just like my parents did in the 60s when they came from India. And what I found is he wanted to make a difference, just like I want to make a difference. I went into medicine, I work a regular faculty job, but I want to do something more. We get paid for working in the emergency department per hour, and that's basically what we get paid for. All the rest of this stuff is like on your own time. But we do it because we want to make a difference, and that is the thing that impressed me most about Frank. So after that dinner, which I feel like is all fate, karma, destiny, is where the Center for Brain Injury Research and Education idea was born. And so the rest of the story has to do with this. Thanks to a very generous endowment and support from the Terrell Family Foundation, we were able to create the center, and one of the first things we did is we got to work. We said, okay, so we need to understand who our people are and what we can do. So the first thing I did was to create a retrospective data set. And while it sounds incredibly dry and boring, people like us actually think it's really exciting, and we spend all these hours and hours like hand crunching numbers and hand entering data to come up with a data set. Why is a data set important? A data set is important because you need to know who it is that you're serving. In your facility, in your population, your county, who are your people? So these are our people, right? So we've looked at 3,000 people in the last couple of years at our Level 1 Trauma Center, and this is the demographic of the people that we see. From these data, we are able to ascertain symptoms that are associated with head injury. This might sound really simple, especially to the people here because you guys are all head injury experts. But even after having been an emergency medicine doc for 13 years, I can't tell you in honesty that every time we see somebody who has a head injury, do we ask them, did you lose consciousness? Did you have vomiting? Did you have seizures? Did you have post-traumatic amnesia? Everybody will say, oh, sure, we check for that. But I'm telling you, I work there every single day. We don't. We look at them and we say, head CT or no head CT. And then if they really want one, we just say, fine, get one. I don't really care, right? What about alteration of consciousness? That is way beyond us. We never ask them, are you confused? Do you have difficulty thinking clearly? Do you feel disoriented? Do we do a mental status exam? You know what our neuro exam says? And I don't know if there's any other ED docs in the audience, but they can back me up. We say neuro non-focal. What does that mean? If there's any neurologists here, they just roll their eyes, because what does that mean? That is not a neuro exam. All right, so then we look at who are our people? What's the mechanism of injury? 46% of our people come in because of falls, 36% come in because of motor vehicle collisions, 19% due to recreational vehicle injuries. When you break down the recreational vehicle injuries, you see 30% are due to bicycle accidents, 41% are due to motorcycles, and then about 13% are due to ATVs. I know there's a lot of pediatric neurologists and pediatric specialists here, so I'm sure you have a lot to say about ATVs and safety related to ATVs. But we live in a college town. We have 50,000 students, and so we do have a lot of recreational vehicle injuries. So it was important for us to understand who is our demographic. So when you have large data sets, some of the cool things you can do with them are you can figure out what are predictors of outcome. And I know that you had seen in Dr. T-Pass's lecture some p-values and some, like blood pressure under 90 is predictive outcome and things like that. We did some similar things, and so this is just a small example. When you break down the cohort and you look at only fall-related TBI, some of the things that predict hospital admission, for example, are age, gender, the presence of seizures, loss of consciousness, post-traumatic amnesia, the severity of the TBI itself, and whether, for example, you're on anticoagulants or antiplatelets. I can talk all day about this stuff because this is like what we do all the time. But for example, like one of our trauma criteria is age over 55. And the older I get, I think 55 is pretty young. And but a lot of people who are even over age 40 are on an aspirin or an anticoagulant for various things, right? Heart disease, thrombotic disease, all sorts of things. And so this is really pertinent to the trauma specialist because if you're on a blood thinner, you have a higher risk of developing blood in your brain. All right, so how do we classify head injury? We basically classified using GCS, right? 1974 study by Dr. Teasdale, and they came up with a score, and that is still today, 30-something years later, what we use to classify head injury. So we say mild head injury is 13 to 15. And I can tell you from experience, it doesn't seem like they're so mild, but we wanted to prove it with data. So last year at the American Academy of Neurology, we presented an abstract called Mild TBI, Not So Mild. And the reason we said that is we looked at all the patients who had a GCS of 15, right? So the mildest among the mild category. And we just looked at their head CT findings. We're a level 1 trauma center, we have surgery residency, emergency medicine residency, and because of that, we scan 97% of our patients who come in with any kind of head trauma. And so the majority of the cohort got scanned. This is several hundred patients. And what we found are these listed findings. What's important here is not like the different percentages that you see, but what's important is the sum total. 27% of our patients who had a GCS of 15 had a bleed or fracture on CT. These are diagnoses that a non-radiologist can see. So like if I can see them on a head CT, then I feel like it's a significant injury. And while for many of them you may say, well, we don't do anything, we're not going to operate on them, we're just going to watch and see what happens, that's all fine. But don't tell me that it's just a little head bleed. If it's my head bleed or it's my loved one's head bleed, it is not going to be a little head bleed for me. So what are some markers of intracranial hemorrhage? Now you see it says Neurocritical Care Society on the side over there. The NCS meeting is actually happening right now in Philadelphia. That's where I was yesterday. And we presented 20 abstracts at this meeting. And so what you're seeing here is like all the latest data that we just presented, embargoed until yesterday. So some markers of intracranial hemorrhage in terms of symptoms include loss of consciousness and post-traumatic amnesia. So it's important for us in the ED to ask that. And some laboratory markers are elevated sodium and higher WBC. Now, if there's researchers in the crowd, we can definitely go into what does all that mean? Are they confounders? Are they markers? Does it have anything to do with head injury? But from a practical sense, as a practitioner, why are these important? So it's funny. I have always worked in academics. I worked for 9 years at Mayo Clinic in Minnesota before coming to Florida. And so, you know, we are so into our research findings, and we're always working at an academic center, so we kind of forget sometimes what it's like for the majority of other practitioners. And so when I was presenting this particular abstract, I was almost apologetic, saying, well, I know it's not a big deal, I know they could be confounders, but, you know, here's our little abstract. And the moderator actually stopped me and said, you know, you shouldn't belittle the findings, because there are places that maybe have a decision point as to whether a head CT should be obtained, whether the patient should be transferred. And so some of these markers can be important, because then they have some data on which to go by. So as a lesson to me. Okay, so you have an intracranial hemorrhage. What about that? You have that. What happens to you? Patients with an intracranial hemorrhage, not surprisingly, are significantly more likely to need neurosurgical intervention, significantly more likely to be admitted to the hospital or ICU. And if they don't get admitted, then they're significantly more likely to come back to the emergency department within 72 hours or be readmitted to the hospital within 30 days. Now, why is that important? From an administrative standpoint, that's important because if the patient comes back within 72 hours, you as the provider who discharged that patient gets called in by your chair and he or she says, so what's up with this patient? How come you have all these 72-hour returns? Why is it you who has all these patients who's coming back? If you're an inpatient practitioner, they say, how come your patient came back after 30 days? You know, we don't get paid for this 30-day readmission. From a patient perspective, if they come back, what does that mean? They're not feeling well. So it's bad on all fronts. So there are several laboratory markers of in-hospital death, including elevated emergency department glucose, elevated emergency department lactate, and elevated INR, and low platelets. And again, while some of these may seem obvious, the reason it's important to look at some of these findings is it may be what you need in order to get your patient where they need to go. Okay, so we did this retrospective data set. We found all these things. We presented all these posters. We have all these data, charts, et cetera. It's all good. It's also good for our, trauma center accreditation because we have, stuff displayed everywhere. But now what? Well, the reason you do a retrospective review is you want to understand your people. Once you understand your people, you want to know where to go from there, right? So you want to improve your practice. Because what did this retrospective data review tell us? It told us that we do a terrible job of evaluating them in the ED. We don't even identify who actually has a head injury. So Dr. Armstrong said one of the things is we need to identify the patients first, because if we don't identify them, then they're not going to get diagnosed. They're not going to get services. I will tell you to this day, even though I work in the ED almost every day, every single time a resident presents a case, you know what they say? They say, oh, but he didn't hit his head. And I say, okay, so he was going at 60 miles an hour and he hit the embankment. And I replay for them again, the same cartoon. I say, so the brain is like flying at 60 miles per hour against the hard stop of a skull. What do you think happened to him? And they go, fine, I'll scan him, it's fine. You know, so every day I feel like I'm educating my residents about the same thing. But so now when I went to the stroke meeting, we got these little plastic brains. What we do now is, if I have to illustrate my point, I throw it across the ED and it hits a wall. So I say, here's his head injury. Okay. So we put together a little protocol. And our protocol is called TBI Adapter. And the reason it's called Adapter is it's TBI assessment, diagnosis, advocacy, prevention, treatment, and evaluation from the emergency room. So here's our little 12-step process. The person has a TBI in the community. They then are transported by EMS or their family member. They come to the emergency department, they are triaged, and they get their usual standard of care, which most of the time includes some kind of physical exam and some kind of brain imaging. At that point, they are approached by a member of my lab team, and many, many people are here. Dr. Peters is here, our trauma nurses are here, and I'm actually going to introduce several of them down the road. I have them on my slides. They are approached by a member of the research team who then asks the patient, you know, we're doing this research project, we're trying to understand traumatic brain injury better, would you be okay with enrolling in our registry? And you know, most of these patients want any kind of help that they can get, so they're really good and they consent. So after we get informed consent from them, we go ahead with the rest of the protocol, which includes neuropsychiatric evaluation in the ED. It includes visual oculomotor testing and TBI education. And then right there from the emergency point itself, we make sure that they have follow-up. I'm going to talk to you a little bit about what we do in terms of neuropsychometric testing. We do the GOAT, which is the Galveston Orientation Amnesia Test. We do a mini mental status exam, which is a more involved neurologic exam than the typical ED neurologic exam. We do Epworth Sleepiness Scale because I really believe that America is sleep deprived and that it results in a lot of motor vehicle collisions. And we also do the Rivermead post-concussive test. In terms of what we do for visual testing, we have this software program. So we're not optometrists, we're not ophthalmologists, we work in a busy emergency department. And so we wanted something that was an idiot-proof test to give us some feedback on what is going on from an oculomotor standpoint. So this particular software program is on a laptop. You can take it anywhere. You can shake the laptop, nothing happens. And it tests for things such as phorias, fusional ranges, accommodative facility, saccades, fixation disparity, and then it also does this test called the 4-dot worth test. And for those who are in visual oculomotor professions, you know what these are. For the average ED doc, they don't know what I'm talking about. All I can say is that it does all these tests automatically for me, so it gives us good data on who potentially has problems that might become worse later. We then have an education module, and I had referred to not having anywhere for the patients to follow up in the beginning. Well, so we kind of ended up de facto being the follow-up TBI clinic. And so our clinic is actually a bench outside the emergency department. And my appointment line is my cell phone. So whenever we discharge the patients, I give them my cell phone. So there's about, I'd say, maybe 4,000 patients out there who have my cell phone number right now. And while you might think it's crazy, I have to tell you, they don't abuse it. The patients only call when they absolutely need to. And I think a lot of people think that's surprising, but they really, don't abuse it. And so if they need something and we can't figure it out, we're ER docs, we're not neuropsychologists, we're not neurologists, we're not neurosurgeons. And so actually our area of expertise is somewhat limited. But I would say the one area of expertise we do have is we're very good at improvising. And we're very good at saying, well, I don't know, but I'm just going to go ahead and try something, right? So we usually meet the patients outside and we see what we can do to help them. And we got some notoriety with that, so we got an article written up about us in the Gainesville Sun. And so from there, we actually got a lot of phone calls saying, well, if you need clinic space, you can work here, you can work there. So the next phase for that is we're actually going to be able to operate out of Shands Bend Plaza, which is a little better than the bench outside, particularly in summertime. So this is our prospective protocol, and this is what we do. And from our prospective protocol, we now have a prospective data set. And so we've got about 800 patients in the prospective data set, and we collect all the following variables, as I mentioned. We also do targeted phone follow-up and clinic follow-up at 2 specific time points. One time point is between 3 to 15 days, and one is 45 to 60 days. What do we do during this follow-up? Well, we have certain things, like, for example, we have this post-concussive survey that we do, and it's a number of questions that we specifically ask them. So, we did this from a research perspective. So for the IRB, we have to say what we're going to ask them on the phone call. And so we have all of the questions listed here that we ask them, and these are things that tell us whether they have, experiencing post-concussive syndrome or not. And then the other purpose of the phone call is really to say, how are you doing? Like, what's going on? Have you been able to go to your appointments? Because honestly, like, I have learned the most about TBI from my patients. Before I started this whole thing, which is really just serendipity, I didn't really know anything about it. And I can tell you, when I was in medical school, it was never really covered. We did a lot of trauma, but we didn't do anything specific to TBI. So looking at these follow-up data, who gets post-concussive syndrome? Some of the things we found is an astonishing 42% of the whole cohort actually experiences post-concussive symptoms. So no wonder they're coming back to the emergency department. And if you look at only the motor vehicle collision component, then 59% of that component experiences post-concussive symptoms. Some univariate correlates that have to do with post-concussive syndrome are younger age and a presence of a headache after the injury and post-traumatic amnesia. When you put all of this into a multivariate regression analysis model, what you find is that headache is still really important, the inability to describe events surrounding the injury or trauma, and post-traumatic amnesia. So therefore, it's really important to ask our patients in the emergency department, are you having a headache? Do you remember the events? And to record these things. So, the emergency department is one place where we see a probably increased or much more disproportionate burden of pre-existing psychiatric disease. Nature of the disease, nature of the emergency department, issues with access. So we were wondering, how does having a pre-existing psychiatric diagnosis such as depression or anxiety or schizophrenia, how does that impact outcome after TBI? Because some might be related, some might be intertwined with that, and so it's difficult, right? So what we found is for all of these symptoms that we ask on our post-concussive syndrome survey, in fact, having a history of psychiatric disease makes you significantly more likely to report these symptoms. Now, you can ask me, so, okay, well, that's cool. What are you going to do about that? I don't have all the answers. I'm just kind of presenting like what we know, and it's a very fluid process, and every day we're trying to figure out what we can do better. In terms of neuropsychometric testing after the acute emergency department visit for head injury, we found that if you have a lower score on the Galveston orientation or amnesia test, you have a higher likelihood of being hospitalized and higher likelihood of having post-concussive syndromes. Similarly, on the Rivermead post-concussion survey, if you have a higher score on that survey, then you are more likely to be admitted to the hospital, you are more likely to be readmitted to the hospital within 30 days, and more likely, again, to have symptoms consistent with post-concussive syndrome. So the burden of the injury, as you have heard over and over already, is not insignificant. I wanted to talk a little bit about our vision testing. So we do a little survey. It's called conversion insufficiency. And so if you have a higher median score on the CSI, which is the conversion insufficiency survey instrument, if you have a higher score, then you are more likely, again, to be admitted to the hospital, develop post-concussive syndrome, and be readmitted to the hospital within 30 days. All of these data are important only because it really tells you what is the downstream of the injury. And it's funny because like I work in the emergency department, so my whole brain is focused on like pre-hospital and the emergency department, and then once they leave the emergency department, to me that's long-term. And I know that actually with TBI, long-term is really well beyond that. All right, so this is kind of a little summary of our TBI clinical strategy. So step one, we did a retrospective survey that is basically taken off of the billing codes or the ICD-9 codes. Then the next thing is we did a prospective evaluation, and we just put this protocol together. When we put the protocol together, we basically got a bunch of people in the room, had their opinions, we put in our thoughts, and then we made a little flow diagram and then got approval for it. Once we did that, we then studied how is our prospective evaluation going, getting prospective data set going. And step 4 is probably the most important, and what it is it's continual patient-centered assessment, feedback, and review. And this is where I'm going to talk about the awesome team that I have the privilege of working with. We are privileged, and again, thanks to the Terrell Family Foundation, to have a clinical resource coordinator. And that is Rebecca, who is sitting somewhere over there. Okay, over there. And so the purpose of the clinical resource coordinator is to connect patients and families to national, state, and local resources that are critical to maximizing their outcomes. So what does she do? She is basically in direct contact with TBI patients who are admitted through the emergency department and supervised by our trauma nurse manager, Donna York, and also an integral member of the trauma team itself. And this is super important because this is really where we are able to connect the families to the brain and spinal cord injury program, to rehab providers, to the post-acute care providers, to legal care, Social Security, access to services. And the reason I'm going through this quickly is because you're all here. And thank you for being here. It is because of all the work that you do that our patients that we see in the emergency department are able to do so much better. What happens to the patients once they're admitted? So of course in my world, once they're admitted, I'm like, okay, they're off my list, I've admitted them, I've done my job. But actually, there's a lot of work that goes on. And so I have the pleasure and privilege of working with this superb team of professionals, and I hope I didn't leave anyone's name off, but one of our nurses, Colleen Council, about a year ago, realized that when patients are admitted to the hospital, the care they get as inpatients on the trauma service is really suboptimal. And the reason she said that is because she works there, right? And so some of the challenges, for example, is patient is admitted, they came in as a trauma alert, they're admitted to the service. Who manages the person who is on the inpatient trauma service? My husband's right now doing a rotation in trauma surgery as the trauma intern. So I can tell you, it's him who manages the trauma patients. And what does the intern know about TBI or trauma surgery? Most interns don't know anything. They just want to make sure their list is done and they don't want to get too yelled at. Of course, they get yelled at all day, but they would like to minimize how much they get yelled at by the attending surgeon, right? So that's who's in charge over there. It's true. I still hear it. And so this stellar group of nurses decided, okay, well, we have to do something about it. They wrote a grant to the quality people at UF, and they got a grant to do this work. And I'm going to talk a little bit about their work, so I don't want to take away their thunder, but I just felt it was really important to highlight some of the things that they are working on. The identified gaps included lack of skills to deal with this challenging group of patients. They're either too restrained or too sedated or too agitated, and this is a huge barrier to recovery, right? You want brain injury patients to recover, but they're agitated because they've had a brain injury. And then if you are the professional who is on the floor with all of these patients, what do? You call the intern and you say, can you write me something? Because this patient is out of control, right? So they don't know what they're doing. They say, well, what would you like me to write for? So they write for something, and then it knocks them out for 2 days. So they have lost 2 days in their recovery because of that. So the goals of this program were to prevent complications from suboptimal activity level, improve medication safety. So you know what happens when we write medications on the floor? You write a medication, there's never a stop. So the medication keeps going, right? And then we add another medication and another medication. And no one puts a stop to it. And if you call the intern who, writes the medications, they're not sure. They're not sure who started it. And they say, well, neurosurgery started that. Maybe we should leave that on there because I'm not really sure. Neurosurgery is just their co-intern anyway. But this is the problem, right? And the nurses who are on the floor day in and day out seeing what's going on can't start or stop the medications. So we wanted to reduce the practice variation, and we wanted to educate the healthcare staff. So some of the achievements that they have already accomplished are environment modifications. So they have posters on the door. They have a poster that helps to keep the lights low, minimize the noise, limit the visitors, limit distractions. And then they also have trained us to speak slowly and clearly. And believe me, for people like me, especially like when I'm stressed out, I talk even faster. And so it was a real education for me to also learn that I have to speak slowly, I have to speak clearly, and try to really communicate. One of the other cool things that they've done is they've used the Rancho scale as their base for deciding how the patients should be managed. And really, they should be the ones up here giving this talk. But there's a sign on the door now, and it's right outside, and it says Rancho, and then there will be a level for the Rancho scale. So you can please do the following things, and please do not do the following things. And then it's updated, and they've also created these badge buddies, which are things that go on your ID card that correlate with all different Rancho scales. And they have activity kits that they've put together that are Rancho appropriate. So if I'm a Rancho level 3, my activity kit has stuff in it that is appropriate to my level of cognitive functioning on that day. Inpatient TBI team accomplishments, they have reduced, and this is all just in a couple of months, they have reduced the number of falls. Why would people fall? Because you'd have a sitter with a sedated patient. The patient would get up to go get something and then fall down. The sitter's job is to sit there, right? We don't really educate our sitters. We call them up, they come here, she's sitting there, or he's sitting there, and people would fall. So we wanted to make sure the number of falls were reduced. They accomplished that. They also reduced the number of restraint hours. If the patients are restrained and they can't do anything, how is their activity level going to improve? They've also done an intranet, and it's actually internet, website for TBI education and resources. And what they did is we just partnered together, and it is on our UF Center for Brain Injury Research and Education website. It's tbi.health.ufl.edu. And they've done health stream education for the staff and the observers. So now the sitters do not just sit. The sitters are educated about Rancho. The sitters are educated about brain injury. They know what to do. They are actively involved in the patient's care. They don't get, paid to just sit there. They've also done unit-based education. When I say unit-based education, we have 5 East, 5 West, 4 East, 4 West, and each of the different nursing units have different types of patients, different job specifications, and so each of these units have targeted education and champion for each one of them, and all our champions are here today. They have also looked into clarifying feeding options for patients, developing of medication protocols in partnership with our pharmacists, and viewing of Rancho score by all disciplines, including these Rancho badge buddies that I said just now. So I hope I haven't gone over time. I timed my talk to make sure I didn't. I just want to say a huge thank you to everybody here. I want to say a huge thank you to the Terrell Family Foundation, a huge thank you to all of my colleagues at UF who I work with. Every day I learn stuff. A huge thank you to our patients, of course, who are really at the cornerstone of everything here. I feel like our part is just a small part in this huge continuum of injury, but if we can make a difference in our piece of the puzzle, then maybe it helps the entire process to be better. If you have any questions at all, this is my email. It's lathagantimd@gmail.com. That's my cell phone. Don't be shy. There's 4,000 other patients who have it. So you can call me or text me anytime. Thank you so much.
So I'm the attending surgeon. I was wondering who I was yelling at for all these years. Those of us who have been involved in our careers, our entire careers in education, know that our daily enterprise is a life and death ongoing struggle of ritual over reason. And what you've just heard, I think, is a very exciting example of what we are trying to disseminate globally, and that is Latha and her colleagues looked at what we were doing, they were doing, thank God it doesn't happen like that now, and challenged themselves, found a way to do it better, and are doing it better. The way they're doing it and doing it better is something we can all take home. But more importantly, what we have to take home is that this is the philosophy we must adopt. This is the process we must begin to follow, because there are lots of opportunities for us as global collaborators to make this entire problem better. So with that, I'm going to give you 10 minutes to, well, I mean, she went over a little bit. 50, so we'll reconvene at 10.